GI pathology, Hirschsprungs disease, malrotation, intussusception, and volvulus. These are very high-yield pathologies when involved in the GI tract. So first, let's start with Hirschsprung's disease. What Hirschsprung's disease is the failure for neural crest cells to migrate. Okay, very important to know that. It causes congenital megacolons, another name for it, that's characterized by lack of ganglion cells or enteric nervous plexus. So you don't have the Auerbach and Meissner plexuses in the distal segment of the colon. Once again, it's due to the failure of neural crest cell migration. All right? It's associated with RET mutations and highly associated with Down syndrome, increased risk with patients with Down syndrome. All right. Now, what's going to happen, the presentation is the patient's going to have bilious emesis, so vomiting a lot of bile, and abdominal distension, and the patient will not be able to pass meconium. So they're not able to pass their first stool within 48 hours because that stool cannot get through to the rectum. All right? What you're going to be seeing is a transition zone on imaging. Okay, so the patient is then going to do on physical exam. If you were to tap the anus area, you're going to have explosive explosion of feces. This is known as the squirt sign, very positive. Okay, and then also on exam, you're going to see an empty rectum on digital exam. Okay, so the way that you diagnose this is by absence of ganglion cells on rectal suction biopsy. So you're going to do a rectal suction biopsy, and the submucosa of the narrow segment is what's biopsied. Okay, the submucosa of the narrow segment, which is usually going to be the rectum, right, is going to be suction biopsied. And if there's an absence of ganglion cells, then it tells you that it's Hirschsprung's disease. All right, and the way that you treat it is via resection. Okay, the rectum is always involved. Okay, overall, that's Hirschsprung's disease. It's very straightforward and high yield pathology to know. Next is malrotation. Malrotation is essentially just described as the incomplete counterclockwise rotation that occurs during embryology. All right. So during development, remember that your whole anterior bowel system leaves your body, and by week 10, it comes back in and rotates around the SMA. But malrotation is the incomplete counterclockwise rotation. Okay. And the patient's going to present with LAD bands. All right. And so those LAD bands are going to be connecting the colon, all right, the right upper part of the colon, like the ascending to transverse portion of colon, to the liver. And since it's malpositioned, the duodenum is going to be compressed by those LAD bands. Okay. This is very important to understand. The LAD bands, the formation of those fibrous bands, are very high yield for malrotation. They love to show you a photo on imaging of malrotation where the small bowel is all just clumped up in the right lower quadrant, and the colon is pushed over to the left side of the abdomen, okay? So make sure that you look up before taking any exam, before doing any questions, look up what malrotation looks like on imaging because they like to show you it. But remember, it's incomplete counterclockwise rotation with LAD bands present. It can also cause a midgut volvulus, okay? Or rotation of the SMA, which can lead to ischemia, okay? So once again, it can cause a midgut volvulus or malrotation of this SMA, which can lead to ischemia. Next is intussusception. Intussusception is just the telescoping of a proximal portion of bowel into a distal portion of the bowel, and it usually occurs at the ileocecal junction. Okay, it's common in infants. Well, not common. It's typically seen in infants, and it's rarer in adults. But once again, it's not like a very common pathology. There has to be a cause for intussusception. What we say is there must be an identifiable lead point. One of the identifiable lead points is any type of infection that could lead to Peyer's patch hypertrophy. Something that's very high yield is that vaccination, specifically rotavirus vaccination, is highly associated with Peyer's patch hypertrophy, which could essentially lead to intussusception, okay, because it acts as a lead point. Now, Meckel's diverticulum in children is also a very high yield associated lead point for intussusception. So you have to know the association with Meckel's diverticulum and intussusception. Very important to know. So Meckel's diverticulum or hypertrophy of Peyer's patches are essentially the two most common lead points for intussusception. Now, this can cause small bowel obstruction, and the patient's usually going to have intermittent abdominal pain, vomiting, and this thing as bloody currant jelly stools. So look up what bloody currant jelly stools looks like. That's what these patients are going to have in intussusception. On physical exam, they could have a sausage-shaped mass in the abdomen. And what happens normally is that the patient usually draws their legs to their chest to ease the pain. On imaging or ultrasonography or CT, you're going to see a target sign. So take a look at what the target sign looks like online or in your books. All right. Lastly, for this chapter is going to be the volvulus. Volvulus is just twisting of the portion of a bowel around its mesentery. okay? And so this can lead to obstruction and infarction. Now, there's different locations in which volvulus can occur. We have the gastric volvulus, which is usually most common with anatomic abnormalities like paraesophageal hernia. We discussed previously that the paraesophageal hernia has increased risk for volvulus. I just want to make that clear. Next is the two most common ones, the much more tested ones, midgut volvulus versus sigmoid volvulus. Midgut volvulus is more common in infants and children. Sigmoid volvulus, which is going to be the most common question you're going to be seeing, is very common in older adults and seniors, okay, senior citizens. You're going to see a dilated sigmoid and then an airless rectum. On imaging, you could see like a coffee bean sign on x-ray, all right? Now, once again, for all of these are very high yield associations. I want you to take a look at the imaging for each one of them. Know what the signs are, know what the presenting signs are and the symptoms, and you should be good to go.